Okay, here we go. I'm going to be talking about some interesting EKG cases I had this last week. Both of these cases just happen to be about wide complex tachycardia. Okay, so this is something new I'm trying because I can't reliably get to didactics on time and I can't, give lectures reliably. So I'm going to do it online so you guys can follow if and when you want to. Just remember my disclaimer, all the stuff I'm talking about, I'm not an expert. I'm not a world-renowned cardiologist. So if you don't like what I'm saying, don't listen to me. These cases are about how and why I practice, like what I do and why I do it. If you like it, then great. If you don't, then don't listen to me. Like practice the way you want to. All right, this first case I had with Dr. Biba. It was approximately 78-year-old male, acute onset of palpitations and chest pain within the last hour. He has a history of aortic valve replacement a few months ago. No known history of coronary disease. On exam, he's pale, uncomfortable, diaphoretic, and a little hypotensive. Okay, this is his previous EKG, okay? Remember, this EKG is to establish a baseline. So I want you to pause your video for a couple seconds and try to just interpret this and write down what you think before you hear what I say. Okay, so on this EKG, remember to establish the baseline. There's multiple abnormalities, but just on the EKG, you can't tell if they're definitive pathologies. Okay, because remember that the value of any test we do depends on the pretest probability, and the value of an EKG depends on what the patient is here for. Remember, anytime I give you an EKG or someone gives you an EKG in the department, the first words out of your mouth should be, why is this patient here? Okay? So the things I see on here which are abnormal is, number one, we definitely have an axis deviation to the left, okay? We also have a left anterior vesicular block. It's up in 1 in AVL, down in 2, 3 in AVF. We also have a borderline first-degree AV block, but I don't really care about a first-degree AV block. The other abnormalities here are in the precordial leads, okay? We have a large R wave in V2 and V3 with T wave inversions in the precordial leads. That can be a sign of many things. It's mostly consistent with right-sided stress or right ventricular hypertrophy, okay? Other things to consider, remember, anytime you see T-wave inversions to precordial leads, think the 3 Ps, okay? A posterior infarct, okay? A pulmonary strain pattern, or low potassium, all right? This gentleman also has these inversions in the lateral leads. Again, what to make of those depends on what's going on with the patient. Another interesting thing here is, number one, he has a terminal R wave, which is an R wave greater than an S wave in AVR or an R wave greater than 3 millimeters in AVR. That by itself is nonspecific. That can be a sign of toxic/metabolic abnormalities, but again, by itself, without any symptoms, you don't know to make any pathology out of this. And the other interesting thing is the appearance of V1 here. Okay, this incomplete right bundle branch block, excuse me, with this like slight ST elevation can be associated with type 2 Brugada. Okay, I don't think this gentleman has Brugada, but remember, type 2 Brugada is an incomplete right bundle branch block with ST elevation of precordial leads. And if you're ever worried about Brugada in someone on the first EKG, you can take the precordial leads and move them up a couple spaces, and sometimes that brings out the pattern. Again, this was just to establish a baseline. So this is what this guy's EKG looks like all the time. Remember, he came in for palpitations and chest pain. Yeah, so this is the EKG that Biba and I saw on arrival. Same thing, pause your computer, take a couple minutes, write down what you think, and then compare it to what I say, okay? Now, the whole thing for this case in this EKG is how do you determine what's VTAC and how do you determine, well, what's SVT with aberrancy, right? If someone has SVT with aberrancy and they have an underlying bundle branch block, if you speed that up, it can look like ventricular tachycardia. So there's many EKG signs and different rules and algorithms to help you determine which one's VTAC and which one's SVT with aberrancy. Don't put too much weight on those, okay? They're not good, okay? If you look up the data on them, they're not always 100% sensitive and specific, and VTAC is a deadly issue, okay? We'll talk about some of these EKG tips to differentiate between the two, but in my opinion, it doesn't matter, okay? When you see a wide complex tachycardia, the first question is, are they stable or unstable? If they're unstable, you use electricity. If they're stable, you can reach for medications, okay? So the EKG findings on here, which do favor ventricular tachycardia, there's many of them. Like most of this EKG looks like VTach except for one finding. We'll talk about that in a little bit. Okay, number one is the axis. Okay, it's down in 1, it's down in AVF. That's an indeterminate axis. That's more likely to favor ventricular tachycardia. Okay, the next ones are fusion and capture beats, which we don't have any here. If you have fusion and capture beats, it's more likely to favor ventricular tachycardia. Okay. The next one is Joseph's sign, or a slurring in the S wave in the precordial leads, which we don't really see. Okay. The next one is the ratio of R to S in V6. If you have an S wave bigger than an R wave in V6, it's more likely to be VTach, which we have in this instance. Okay. The next one is the Brugada interval, which is the time frame from the beginning of the QRS to the peak of the S wave in the precordial leads. And this one's pretty long. Okay, so a couple things. I've shown this EKG to a couple people, and they get confused by V3. They're like, oh, well, V3 looks narrow, so this can't be a wide complex tachycardia, and that's false, all right? Remember, all of these QRSs vertically are the same, so this QRS is the same as this QRS. So you pick a time where you know the QRS starts and ends. I mean, we can clearly see it starts here and ends there. When we follow this down, we can see, boom, that's the beginning of the QRS, and we follow this down, that's the end of the QRS. So this whole thing right here is the QRS, and it's definitely wide. Other things on here which point more towards ventricular tachycardia is this lack of consistent morphology in the precordial leads. Okay, in VTach, you would expect all the precordial leads to be pointing in the same direction, and these ones are not. You can see this peak is upright and maps out to about like one small box after this big line. Same thing here, but when we follow this down, it doesn't. Like it's down here. So most of this stuff favors ventricular tachycardia. The one thing here that doesn't favor ventricular tachycardia is the heart rate. I mean, this is pretty high. This is over 200. Over 200 normally isn't associated with ventricular tachycardia. I have seen cases where it's often associated with this fascicular ventricular tachycardia, which is pretty rare and only responds to calcium channel blockers. But that's the one thing on here that doesn't indicate VTach is the rate. Like the rate here ports more towards like an atrial arrhythmia, like either atrial flutter with 1-to-1 or an SVT. So that's all the fancy nerd EKG stuff. Again, we don't treat an EKG, we treat a patient. So the question is, what do you do? Okay, so this guy comes in, acute onset. He looked bad. Like he was pale, diaphoretic. I mean, he was awake and talking, but he's like, man, I got chest pain, and he was all gray, and he was hypotensive. So we were like, man, this guy's definitely unstable. He's got chest pain. Let's cardiovert him. So we sedated him. There's many different options for sedation. For me, for electrical cardioversion, I like propofol because it's fast on, fast off, and you don't have to have these patients like all the way knocked out. So we gave him 60 milligrams of propofol. He went to sleep, and we did a 200 milliamps of synchronized cardioversion, which worked for about 10 seconds. He go back into normal sinus rhythm, then he went back into the wide complex. He was still sedated from the propofol, so we tried 2 more times with electricity. Same thing would happen. He would convert for about 10 seconds and then go right back into the wide complex. So this is an interesting case and something I haven't had a lot, where electricity fails to cardiovert someone. So now we have a problem. We have an unstable patient with a wide complex tachycardia where electricity is not working. What do you do? Okay. So same thing, I want you to stop and think, like, what would you do? So the only other option you have is, well, number one, obviously we consulted cardiology, right? Number 2, we chose procainamide, and we'll get into that later. He did very well in the procainamide. About halfway through his bolus, he converted back into normal sinus rhythm. And this is his EKG after he converted. Again, there's many abnormalities on here, which I find interesting. Let's go through them. Number 1, I mean, same thing. We have a complete right bundle branch block. And if you look at it, the morphology of the right bundle is odd appearing, right? We don't have the classic RR prime. And the ST depression here, again, looks odd. Now, remember, in a right bundle branch block, ST depression or T-wave inversion of core leads is normal, okay? And also, I hear a lot of you residents trying to use Scarbosa's criteria when we talk about a right bundle. Okay, don't do that. Remember, Scarbosa's criteria is only for a left bundle branch block or a ventricular paced rhythm. Now, my contention why these QRSs look so odd is because there's a fractured QRS in here, which is, I think, subsequent to his valvular surgery. Remember, a fractured QRS is a delay or a blip in the QRS, and that's a sign of electricity going around something that's electrically inert. My contention is that it's his valve repair, but again, I can't confirm that. The other interesting thing we have on this EKG is we have a pretty big S wave in lead 1. Okay, technically, you would qualify this axis as indeterminate because it's down in 1 in AVF. But the thing about a right bundle branch block is normally you do have an S wave in lead 1 that's wider than the R wave, but normally the S wave is smaller than the R wave. And that's not the case here. You can see that he's got an R wave that's smaller than an S wave. And the thing is, people call this indeterminate axis, but for me, anytime I have a large S wave in lead 1, I am calling that right axis deviation. Okay, and I'll get to that in a little bit. Why? Because the thing is, well, let's just get into it now. So here's the axis of the heart, right? Like the normal axis is over here in green, right axis deviation is in blue, left axis deviation is purple. This extreme axis, or this northwest part of like the axis, is what we normally call like indeterminate. But my contention is, all these things we're measuring in the EKG is just vectors, and vectors are additive. And you can add them up to get that way many different ways. Like you can start here and you can go extremely left to end up here, or you can start here and go extremely right. So my contention is like this indeterminate axis is not really indeterminate. It's both extremely right and extremely left at the same time. And again, what I think is, the reason we have this right axis deviation, and also if you notice we have a pretty big terminal R wave up in AVR, I think that's because we start them on the procainamide. Like procainamide is a sodium channel blocker, so what I think we're seeing here with these electrical abnormalities is the effect of the sodium channel blocker from procainamide, but again, I can't confirm that. Another thing to bring up is one of the side effects of procainamide is it widens your QRS. That's one of the things you have to look for when you're giving it to them. So if you think about it, if you have a patient on procainamide and their QRS gets wider and they become more unstable, what I would do is turn off their procainamide and give them sodium bicarbonate, okay? Because procainamide is a sodium channel blocker. The antidote for sodium channel blockers is sodium bicarbonate, either by inactivation of the pH or giving them more sodium to overcome like the blockade. No one really knows. All right, so the next case, this case comes from Dr. Russ Johnson. I'm not sure who the resident was. There's a 67-year-old male with past medical history of myocardial infarction. Says it was accompanied by the use go ahead and had 2 stents placed. Okay. Today he was coming in due to fluttering in his chest and feeling like his heart is racing. He's also experiencing some dizziness at this point. It has never had this happen before. He feels that he has had AFib a couple of times but has not been treated for it at all. According to him, the symptoms started yesterday and has just started worse Advair. He currently denies any chest pain or shortness of breath. A couple things to learn from this history. Number 1, I can't read. Number 2, we never check our spelling. Okay, so that's the history for this gentleman. One thing to note is he has a history of myocardial infarction. Okay, remember I say this all the time, the value of any test depends on your pretest probability. It's the same thing for diagnosing ventricular tachycardia. I read one study that, if you're over the age of 55 and you have a history of coronary heart disease, like your pretest probability for ventricular tachycardia is like over 80%. Because you have a history of coronary heart disease and an MI, you get a scar in the heart, again, which is a structural problem, and you get scar-mediated ventricular tachycardia. So if you're a person over the age of 55 with a history of MI and you come in with VTAC, or you come with a wide complex tachycardia, it's already probably VTAC, okay? Another reason why all that fancy EKG stuff doesn't matter, all right? So let's get into his EKG. Here's his first EKG. Again, pause and take a look at it and write down what you think. Again, on here, we have multiple abnormalities. The obvious one is, the rhythm is definitely, irregular and fits with atrial fibrillation. It's a little fast as well. An interesting thing to note here is it almost appears that we have borderline electrical alternans, and that's a beat-to-beat variation in the amplitude and or direction of the QRS. And you can see it pretty good in 2, okay? Now, if we see that, we're concerned about a pericardial effusion. Things on here which don't point to a pericardial effusion is we don't see like diffusely low voltage. And again, the electrical alternans is not really that complete. what I think is going on is, well, the heart is rocking back and forth as it beats, and it's beating so fast that might change like a beat to beat amplitude of the QRS. But again, I mean, the main thing is the guy came in with palpitations, right? So this is his first EKG. They start the normal like workup and stuff, and during his stay, this happens, okay? Now, same thing, pause your computer, look at the EKG, write down what you think. Okay, so now, same thing I was talking about before. The question here is this VTAC or not? And if we go through most of the electrical stuff, most of this does not look like VTAC, okay? Like, number one, we have a determinate axis, right? Like it's down in 1 and up in AVF. We can see a pretty good example here of like a fusion beat right here. Like this is what a fusion beat is. Like it's a combination between like both the wide complex and like the narrow complex here. Things on here, again, we have an R wave bigger than an S wave, which points against ventricular tachycardia. Okay, we have all of the QRSs pointing in the same direction, which is more evidence that it's SVT with aberrancy. We have a pretty big Brugada interval, right? From the onset of the QRS to the peak of the QRS is really, really long. So most of this does not look like ventricular tachycardia, but guess what? It was VTAC, okay? The gentleman we saw first, this gentleman, he went to the electrical physical lab and it wasn't inducible VTAC. They found an ectopic foci in his atrium. Okay, so this wasn't atrial arrhythmia. But they did the same thing. Okay, they started him amiodarone and they put in an AICD, which I agree with, right? Because whether it's VTAC or whether it's aberrancy, this gentleman had an unstable wide complex tachycardia. And the best treatment for that is electricity and medications, which they put him on. Same thing for this gentleman. They took him to the electrical physical lab and found inducible ventricular tachycardia, and they put an AICD in him and put him on antiarrhythmics as well. But again, this gentleman's pre-test probability was high, right? He's an older gentleman with a history of a myocardial infarction. And let's see if we can find, well, we do, okay? So the other thing on this EKG, if you look pretty closely, especially on these beats right here down in AVF, you can see there is a fractionated QRS, right? Like there's a delay in the QRS, like a blip in the QRS, but it's less than 120, so there's something electricity has to go around. Again, most likely for this gentleman, scar-mediated ventricular tachycardia. So this is, everyone learns differently, okay? And like I tell you guys, the best teacher you should ever have in residency is yourself. I'm a visual guy. Like if I see things visually in my mind, I can help like remember it. And this is how I remember like wide complex tachycardia, okay? First thing, up top, and this is important, okay? The heart rate for wide complex tachycardia should be over 130. I'm sorry that says 120. I don't know why I did that because I'm an idiot. Okay, a heart rate over 130 or a QRS duration less than 200. Okay, that is consistent with VTAC. If you see a heart rate less than 130 or a QRS duration over 200, stop what you're doing and think. Okay, because that's not VTAC. That's an accelerated intraventricular rhythm. And if you treat those people with antiarrhythmics, you can make them worse. Okay. AIVR and an acutely sick patient, think tox or metabolic things, like tox like drugs, be it street drugs or prescription drugs. Metabolic is often either hyperkalemia or acidosis or anything that affects connexin 43, and we'll get into that later. Okay, so for wide complex tachycardia, again, with a caveat, heart rate over 130, QRS duration less than 200. The two subtypes is either monomorphic ventricular tachycardia or polymorphic ventricular tachycardia. The most common cause for monomorphic ventricular tachycardia is structural heart disease, okay? For both of these ventricular tachycardias, we have two subtypes. For monomorphic, we have sustained monomorphic VTAC and non-sustained monomorphic VTAC. The distinction thing between those two is 30 seconds. Sustained is more than 30, non-sustained is less than 30. Now, the best medication for any ventricular tachycardia or unstable wide complex is electricity, right? Sedation, synchronized cardioversion. I always go as high as you can. I don't see the point of starting low and bumping up. Electricity is the best medication. But if they're stable, then the question is, well, what IV medication do you use? For sustained monomorphic ventricular tachycardia, the data confirms that procainamide is better. Okay. For non-sustained, beta blockers is better. Under polymorphic ventricular tachycardia, same thing. We have two subtypes. And the thing that distinguishes the two subtypes is the prolonged QT, okay? Polymorphic VTAC with the prolonged QT is torsades, all right? Torsades is a form of polymorphic ventricular tachycardia. I can't tell you how many times I've seen people get this wrong, both med student, resident, attending level. If you don't have a prolonged QT, you cannot call it torsades. Okay, that's very important. Let me say it again. If you do not have a prolonged QT, you cannot call it torsades. All right. So again, the two different things is either torsades or polymorphic ventricular tachycardia, and the differentiating thing is prolonged QT. The most common cause of prolonged QT in America is medications. Polymorphic VTAC with a normal QT is just regular polymorphic VTAC, and the most common cause for that is acute coronary syndrome. Best IV medication for polymorphic VTAC with a normal QT is amiodarone. Best medication for polymorphic VTAC with a prolonged QT is magnesium. Also, for polymorphic VTAC with a normal QTC, remember the underlying cause is ACS. Okay, yes, convert them with like electricity and amiodarone, but treat the underlying ACS, or you're not going to make the issue any better. All right, here's some of those visual things I was talking about. This is the Joseph's sign, okay, or a notching in the S wave in the precordial leads. And this is that Brugada interval I was talking about. From the beginning of the QRS to the peak of the S wave in the precordial leads, if that's over 100 milliseconds or more than 2.5, more likely VTAC. And here's better examples of the fusion beat and the capture beats, right? Again, more likely VTAC, but again, you can't differentiate 100% with these algorithms and these images. Here's some of the data, right? Randomized comparison of intravenous procainamide versus amiodarone for wide QRS tachycardia. Now, in this study, they threw out people who were having, acute heart attack or who were unstable. Okay, so this confirms, procainamide, converted 6-7%, where amiodarone only did 38%. There was some more problems with procainamide people as far as widening QRS and stuff, but according to the numbers, procainamide is better than amiodarone for stable monomorphic ventricular tachycardia. Okay. What about lidocaine? The comparison procainamide and lidocaine in sustained monoventricular tachycardia. Again, procainamide was found to be better. 12 of 15 patients, and procainamide converted. Only 3 of 14 patients with lidocaine converted. Here's some more references I found. Okay, here we go. Without severe failure in MI, the first choice is procainamide. Okay. In the setting of acute MI, amiodarone is better. So that's the thing, is if your arrhythmia is from an acute MI, that's the one time amiodarone is better. We don't use a lot of procainamide because people are afraid of it. The dosing is harder to do than amiodarone. Amiodarone is easy. Like, you just give them boluses, right? For procainamide, it's 10 mg per kg IV dose over 20 minutes. And again, you monitor for hypotension or prolonged QT. As I stated, in this chart, these medications, are the best ones according to the data. But if you were to use another one, that's not wrong, right? Like if you had monomorphic VTAC, like I'm going to use amiodarone or lidocaine, that's not wrong. Just these other ones have like a better chance of converting. And that's the thing, for this case, people are like, it was from the atrium. Was procainamide like the drug of choice? Like, not really, okay? Because procainamide can convert like atrial arrhythmias. It's not as good as like the beta blockers or the calcium channel blockers, but it is an option. Because that's the thing for me, when I go to this chart, like if you truly have no idea what's going on, like they're wide, complex, and you don't know what it is, you're sure it's not AIVR, the safest medication is procainamide, right? Because another thing to consider with these wide, complex tachycardic patients, is this WPW with orthodromic conduction? Again, for that, think about your pretest probability, right? Like the patient we saw was in his 70s. He already had heart surgery. He's got 50,000 EKGs in the computer that I can look at. Like, number one, I can look at an EKG to see if he's got WPW. Number two, do you think someone missed that? Like, do you think they didn't evaluate him for WPW before they cut his chest open, right? But if, let's say it was someone different. Let's say it was a 32-year-old gentleman who's got no EKGs like ever in the computer system will shoot, I'd be worried that WPW is a possibility for him. So if you truly don't know, procainamide is always like the safest medication to give. All right, that's my presentation for this week, or this time. Like I said, I'll upload videos whenever I get like cool cases and stuff. If you have any questions, you can write them in the comments, but I'm not good at computers. A better recommendation would be to find me in the hospital and ask me in person, because I'm better at explaining stuff like that. All right, that's all I got. Peace out.